Welcome to the Heart Rate Variability Podcast. Each week we talk about heart rate variability and how it can be used to improve your overall health and wellness. Please consider the information in this podcast for your informational use and not medical advice. Please see your medical provider to apply any of the strategies outlined in this episode. Heart Rate Variability Podcast is a production of Optimal LLC and Optimal HRV. Check us out at optimalhrv.com. Please enjoy the show. Welcome, friends, to the Heart Rate Variability Podcast. I am Matt Bennett, and I am excited to be here with Dr. Jennifer Addleman and Dr. Nicholas Lackey. Nicholas is a friend of the show. He wasn't Dr. Nicholas last time he was here. So I know how much hard work goes into both your degrees. So congratulations, I know, to both of you. I read your article and started bugging you about recording an episode. I know it was public. I got April, late April is when it went online. I think it was published maybe in the summer edition of the AAPB Journal, but that means you were working on it for months before April. And I just found, I read, I think almost every HRV article published out there, which didn't used to be like 10 a day, and now it is. But this was one that I feel the field needed this article. And that's why I was so excited. And we've had to reschedule a few times, but I wasn't going to let you all go without talking about it, because I really think you hit on a key piece of where we're at in the heart rate variability mainstream journey, and I loved your approach to this. So, Dr. Lackey, you want to start out? I know you've been on the show before. I encourage people to go back to that article, but just in case maybe our listeners didn't listen to that, I'll give you a chance to introduce yourself first.
Of course, and as getting through grad school and new experiences, much has changed. So I am Dr. Nicholas Lackey. I'm currently a psychology postdoctoral resident at Kaiser up here in Northern California now. I was at VA Loma Linda last year for my internship, so I will soon hopefully be licensed once I do all that fun stuff. I am board certified in biofeedback. I had the opportunity to be able to do that already throughout my grad school. It's something I'm very clearly passionate about. Our last podcast and my dissertation was more about central sensitivity and chronic pain and its relation to heart rate variability and just overall body kind of sensitivity. So we'll see where my career takes me, but this is definitely going to be a central point that I hope the rest of my career takes, and hence why I'm back.
I'm excited to watch it as well. It's kind of like the nice thing about being the old guy is, we met, I think, 2-3 years ago now at the AAPB conference. And it's just like, boy, this fellow nerd. And we use nerd as a compliment on this podcast, and just a fun dude to hang out with as well. So I'm glad to have you back on the show. Dr. Addleman, I welcome, first time on the show. I'd love to introduction of yourself, and just kind of, I would love to, with that introduction, how did you come to heart rate variability? When did this hit your radar? And I just love to learn a little bit more about, kind of leading up to some really great publications.
Absolutely. I'm Dr. Jennifer Addleman. I am a resident physician currently training at Sutter, Roseville for my first year of residency. And then I'll be completing the rest of my physical medicine and rehabilitation training at Stanford. I'm also a strength and conditioning specialist. So I've coached a lot of athletes and active individuals through strength classes. So I'm just really passionate about movement. My plan is to eventually specialize in sports medicine. And so HRV was a technology that I kind of found more personally initially. I was using various devices, kind of trying to learn more about the technology, figure out how it could be applied for my own fitness. But then really realizing that, this has a place outside of just fitness. This has a place across medicine. And really, I think it will continue to influence my career as a clinician, as a physician, but not just in sports medicine, hopefully eventually across the board as well. And so that was kind of how I found HRV, mostly in medical school was when I was exploring it, which is when Nick and I met, became friends, and decided to publish some papers together.
That's awesome. So I'll just kind of throw this out. Either of you can take this one. but I love the idea of a narrative review. It was something you don't see a lot, especially the heart rate variability, where it's like we're looking at HRV, we're looking at an intervention control group kind of study. This was very, very different. So I'll just throw, how did this idea come up to approach this literature review in this narrative format?
As with almost everything, it hadn't really been done well yet. And so I as we would have loved to have done more, maybe even do a full meta-analysis or do a systematic review where we can really deep dive in the literature. But given the literature that was kind of there at the time, we did not know if that effort would have paid off as much for going that deep, especially given some of the methodological limitations and stuff like that. Um, we were glad, and one of the actual recommendations that we got from the reviewers is there had been a brand new end of 2024, if I'm remembering correctly, just, hey, let's re-standardize everything HRV, since I believe the last one before that was the 90s. And so, fantastic, great, we can include that because, as you're saying, with this article, what ended up being a full call to the field of, hey, let's start this more. It can be useful, or at least let's ask the question, where can it be useful?
Yeah.
That then is exactly the article we want other people to also read so they can be standardized and say, hey, this is where it has validity and this is where it doesn't, and we can be more confident.
Yeah.
I think to add on to that, each field that we explored had a very different amount of papers and a very different amount of depth. So that made a huge difference in, if we tried to do, a very standardized meta-analysis, we would not be able to do it with the variability that's going on with all these papers. It was so heterogeneous that it just made a huge difference in how we would be able to analyze. And so even if we did a meta-analysis, I don't think it would have worked. I don't think it would have been a good paper because I think the research isn't standardized enough, which we kind of talk about in the paper. And so really the narrative review was the best way for us to kind of assess where are we at when it comes to applying HRV across different healthcare fields. And kind of being able to call out the differences in how much it's studied in one field or another without directly comparing them to each other, if that makes
Yeah.
sense.
And one of the things that, again, as somebody who obsessively reads HRV research, it's an interesting thing how it's applied. And with your, you touched on this as well. It's like there's 5-minute readings, there's 24/7 monitoring, that there are all these different approaches, and they lead to, I mean, they're just different data too, and putting these pieces together. I mean, what I kind of like about HRV is it's kind of a new enough science, whereas if you want to make a point that HRV is positive in some way, there's probably a article. Now, whether it's a good article, whether there's a meta study is a different thing.
Mhm.
But hey, if you want to show turmeric's impact on inflammation and HRV, probably there's something out there for it. So I'm curious as you kind of go through this, and as you, I know this kind of mirrors as your careers are kind of, again, both of you newly minted doctors, kind of how you kind of saw this across different fields and how they were using it.
Uh, I personally wrote the psychology and psychiatry section, so I'll take that first. That is very evidently the hugest, largest amount of the HRV literature, just because of the autonomics related to mood, flight, fight, freeze. Like, that's just inherent and kind of there based on our perception. So, like, that I scratched the surface and did the best that I could. But really I was quoting other reviews and meta-analyses themselves, unless there was something really specific when I was bringing up more of the biofeedback stuff, which again is my bias. But if anyone else did read kind of the paper, that literature for maybe where HRV could be helpful, let alone clinical implications of biofeedback, just not even there.
Yeah.
Some fields were more of just the, hey, this one specific diagnosis, which again, very much get. We need a theoretical reason why HRV would be affected, while also why would HRV be a clinical indicator of said disease, let alone then asking the clinical improvement question. You really need to build that logic. And so it just wasn't there for a lot. Clearly, there was a little bit more in cardiology because the heart cardiology there and some of the foundational initial metrics, of course, came from cardiology and psychophysiology together. And I know if I'm remembering correctly, there's still newer interest in POTS that's ongoing,
Yeah.
but specifically going into those other fields and other diagnoses, those haven't been explored as much yet. I'll let Jen talk a little bit more about critical care and things like that, given that medical side of the aisle and everything. But the answer really was across the entire team that helped with this, there wasn't a lot. And the methodology themselves, we heard our co-authors get frustrated because it was just not standardized within even the field of let's say rheum, cardiology, pulmonology, anything like that.
Yeah, absolutely. I mean, I definitely had to hold Nick back from going too detailed on his psychology section because there simply is so much research there, and we
Yeah.
know that, right? And definitely cardiology, like you said, some very fundamental papers that really shaped HRV. But there were definitely some other areas where there was less. Interestingly, there is one application actually of HRV that's really like already standardized, applied across the board. It's even taught in medical school, which I learned about. And really, that one area is infant health monitoring during
Yeah.
labor, right? So that is where we see it already integrated into healthcare. But really, in any other application, we're not applying it. We have plenty of patients throughout the hospital hooked up to telemetry, continuously monitoring
Yeah.
their heart rate, continuously monitoring various measures. But HRV is absent from that. And especially in critical care settings when, every second can matter, every minute can matter, right? It would be helpful to have another tool that can maybe predict clinical deterioration before it happens, right? That hemodynamic instability, if we can detect that a few minutes in advance, even that sounds like a win. So there were definitely some really interesting papers talking about its application, in critical care, especially in areas of the hospital that patients are already monitored on telemetry. It could definitely be integrated into that technology already. But also for chronic disease monitoring, there's a lot of diagnoses like what Nick said, with POTS and many other diagnoses that we don't really have good monitoring established, right? Some rheumatologic disorders as well. We kind of just wait for them to become a problem and then we treat it in the moment. We treat the acute exacerbations. And of course, there are chronic medications that people are on, but as far as a monitoring perspective, we just don't have a ton of options, right? And so those are areas where, I would almost suggest that HRV, we should really be not only studying it, but maybe even applying it, given that we just don't have much there to really support patients with these diagnoses. And in addition to the things like cardiovascular disease that we know, we'll see that with HRV. And we have a lot of other monitoring, but we could always add HRV on top of it. So lots of really, really interesting papers. But as far as teasing out, like, are we predicting prognosis? Are we predicting clinical deterioration? Are we predicting, response to a treatment, progression of a disease? Very, very variable depending on the diagnosis. And the papers varied a lot, even for one diagnosis, lots of different answers. So we were really kind of finding that, our hands are still tied with some things, but hopefully we can start applying it more, getting more of that good research out and, getting some of those answers.
And Dr.
Yeah.
Addleman, I'm curious about your kind of journey with this of, being in the performance space. There really, and my background's in mental health. I was, I'll put in air quotes because it was so long ago, an athlete at one point in my life. So it's like, in some ways, I mean, obviously heart rate variability has been around it's been around since, we
For a while.
but for a long time since we had
Family.
hearts that are beating,
Yeah.
but we've known about it for hundreds of years technically, but been studying it for decades now. And then I'll call it the wellness slash performance space, not necessarily what I would call medical, kind of grabbed a hold of it. I think rightfully so, they saw like the potential even before my folks in mental health, I think, got there per se. And so, but you know, the wellness space is a very different space than the hospital, because I totally agree with you. If we're getting HRV data and we got a reason to hook somebody up, like it, why aren't we paying attention to it? I think that's a brilliant point. And just kind of like putting your two worlds together about how the wellness space is ahead of the curve in so many ways, and we need medicine to catch up, and just kind of how that experience has been holding both sides of that in your personal and professional experience.
Absolutely. So that is one of my passions in my career, is really bringing together the strength and conditioning world and the sports medicine world kind of together, right? And especially being a coach myself, having worked with patients in that kind of a setting, work with clients in that setting, and then now on the other side, kind of on the medical side, it's interesting to kind of see how each group really sees HRV differently. And Nick and I actually published a different paper talking about HRV's applications in strength and conditioning specifically, not even sports medicine, but just strength and conditioning, because HRV is really a technology that's being adapted for many different applications. And we were really trying to see how many of those applications are really researched thoroughly, and how many of the claims that we're making about HRV from a fitness perspective, how many of those are really backed by research? Just kind of evaluating what what it looked like in that at that time. And there was definitely some interesting research. I mean, there were some good studies that showed that, you know, HRV guided training can be really helpful, where basically, you know, each day you would look at your HRV from overnight from one of these devices. You could see, you know, if my HRV is lower, you know, outside of like my window, so that would be like half a standard deviation below. There's a couple different math equations you could use, but if it's outside of your normal window and it's too low, then you could do maybe a rest day, or, you know, a lower intensity day, compared to a day where your HRV is high or within your normal. Then you could do a high or a moderate intensity training day. And there were some good studies that showed that, you know, that could be helpful. Again, very variable. Lots of different athletes this was applied to, different sports, different training sessions, right? Like there was some heterogeneity in that literature as well. But that is definitely a way that HRV is being applied in more of the strength and conditioning realm. But it's interesting to kind of see the intersection where it meets medicine, because, you know, there's a lot of medical data that is protected. And we were kind of realizing that this is medical data, but it's not technically claimed as such.
Right.
And so we are, you know, allowing, like, lots of coaches have access to this data, lots of non-medical providers have access to this data. You know, what does that mean if we start making it more of a health metric? And should that have the same data protections as other medical data? So we found some really interesting things with that paper, and really just trying to figure out, you know, what is within the scope of a strength and conditioning professional who is maybe seeing this data, what can they do with it compared to what a medical provider could do with it.
Right. And I'll still talk to cardiologists who, oh, I think I remember learning about HRV in school, like 20 years ago. Like, I like
Absolutely.
Google it, like just Google
Yeah.
it, you know, I'm not, you know, and then they come back to me and say, wow, I should be paying attention to this more. So it's just this,
Yeah.
it's kind of the Wild West, but with all this really hardcore science. We're not, well, this is where I want to get to Nicholas here with this question. I want to say we're not making up this metric, but there is a gazillion readiness scores out there, if you want them, that aren't validated and aren't disclosed of how we figure these scores. So I want Dr. Addleman to like me. I think Dr. Lackey is forced to like me because we're fellow nerds here. So I'll throw this, but Dr. Addleman, jump in here as well if you want to dive into this water. So one of the things that I don't know what to do with is, you know, we published in this podcast This Week in Heart Rate Variability, where I think I probably catch most of the research published out there and then, you know, bring that into a condensed way where viewers can explore it in more, or listeners can explore it in more detail. You know, the one metric that keeps showing up is low frequency over high frequency. And this is where this is where we get a little nerdy with it. There's been great articles, a great article published that we should not use that metric, especially and say that it's a measure of sympathetic activation. And I would say every third article I read, peer reviewed, has low frequency over high frequency as a sympathetic activation. And then, having a foot in the wellness space as well, one of the reasons I started a HRV company was what's a readiness score? And if I'm a clinician working with somebody who might self-harm or relapse, I need to know how you're giving them data, and it was proprietary. So, it speaks to kind of what you were saying about, what are non-medical people doing with this? And as a master's level clinician, I don't know what to do with it because you won't tell me how you figure it. So with that rant, Dr. Lackey, as you sort of did the deep dive and being in the mental health arena, and I know you did that for this paper, I'm curious, was it frustration? Was it curiosity? As somebody I know wants good data, I'm just curious about your journey into this, research.
A heavy dose of pragmatism. Because I think with everything that Jen was even saying there about the medical side, there does need to be that heavy dose of pragmatism. The answer is we simply don't know right now. And I don't think any of us can sit here and lie and say that everything's going to be helpful. No, there's going to be certain metrics, certain diagnoses, or even bringing up the cardiology example. There's a certain point when the heart's just freaking out because of another medical condition and HRV will be unreliable.
Yeah.
But right now, we don't even know when and where that switch is within cardiology, right? And that's the field, the medical field that studies the heart. Getting back to just that LFHF and thinking about how the field communicates it, that's why already in the first few minutes of this podcast, I brought up that other paper, because however we can do to perpetuate the understanding of core HRV norms, just like thinking even core understanding of statistics for why we have a replication crisis of things, like the more we can make sure that we are doing the best that we can, the more the meta-analyses we already talked about can also be more helpful and more valid. Because it's not just about the effect sizes. They also look at methodological quality, methodological rigor, and even a lot of those are not as great as we would hope. It is pretty well known that like the pharmacology studies for mental health medications, they're great because of their large sample size, which means they have a higher methodological quality, but the effect size is relatively similar, right? Um, so the unfortunate answer is we don't know. I do think it is still very helpful with their HRV is at to be pragmatic and just be like, hey, great, we see these associations, so we can start continue to build that logic to clinical efficacy or delineating between different diagnoses and everything like that. Um, it was interesting when we were doing the study with Dr. DeBlois. That's his name, right, Jen? I believe I'm butchering it. Okay.
Yeah.
He was a researcher back on the East Coast that we were Jen was able to get a good relationship with him, and he came on, and him and I had a solid 30 minutes where Jen was just sitting there, and him and I were going back and forth about just kind of some of those metrics. And he was also more on a similar thing of pragmatism of just like, what is helpful right now? What is presenting with us good data? That is still very helpful right now. I hope within my lifetime we get that switch to, well, now we can be very specific. We know this HRV change is because of this diagnosis, not because of the anxiety they also have on the inpatient unit. Not because also they just got this medication and now that's another complication to interpreting HRV at that point. It's so much methodological that also going back to the like what epoch, what time unit are we studying?
Yeah.
Doing biofeedback. I can minimize it to the 1 hour and how I'm talking to them and being able to see the data on the screen. So that eliminates so many other variables that I as a clinician can then trust it. I do see that as much as I want to be hopeful, and I am hopeful about it, we need to be honest about those limitations and this is going to sound terrible for other medical providers, but like putting even more on nurses for, okay, are there other behaviors and other things we need to be looking out for, somehow coding for, so that that way we can trust HRV in an inpatient setting, right? That would be another thing, like midway through that literature, we'd also have to start controlling for, or maybe even do that earlier so we can do more effective HRV ideology in those settings.
Yeah, I mean, Nick is bringing up a really good point that, HRV is very sensitive, but so non-specific that in a medical setting with patients with many comorbidities all going on at the same time, we have the congestive heart failure, on renal failure, on, everything coming together. I think it is an incredible technology that I think we'll need to really fine tune to figure out the nuances. But I think from a provider perspective at this time, it's really hard to be able to say, HRV alone is going to determine my clinical decision making. And
Mhm.
which is why, one of the great things about medicine is that we have lots of other measures too,
Yeah.
right? So, you can look at somebody's blood pressure and go, am I concerned about this blood pressure or am I not concerned about it? And then you could see maybe the blood pressure in combination with the heart rate and then in combination with the HRV and go, uh-oh, like something is going on, right? So it really is just, I definitely don't expect that HRV is going to become a standalone measure that will give us any clinical decision-making ability. But in parallel, and in addition to all of the other monitoring tools that we do have access to for chronic disease monitoring and on inpatient units, let's do it. Let's use
Yeah.
it, but we do need better information to be able to really cite, what does this mean and how do I use this in a clinical setting? Like if somebody had a stroke recently, and they're in an inpatient unit, how do I use HRV? And then, let's say it's weeks after they're in rehab, now how do I use HRV after their stroke? What about 6 months after? So really trying to tease all of that out. We just need a lot more good information.
And did you, I mean, as a medical doctor, you know, uh, do you feel like, let's say you see heart rate variability, you get an alert that, let's say somebody's in the hospital and their heart rate variability is dropped 20% over the last 3 or 4 hours. I'm just kind of curious because your point is so incredibly just brilliant. Like we've got to take these things into account. I just assume that it's one marker and it may be a leading marker. It may be a lagging marker depending on the condition, but it just seems like, it's another piece of data in that environment that we've got to be paying attention to. And if it's going, I always like, if it's dropping, ask the question, why? And that gets us part. But I just kind of like, do you think or how do we get HRV on people's radar enough to say, we need to include this in the data that you're looking at, in the ER, in the ICU, or in a inpatient sort of setting?
Absolutely. I mean, I'm not going to pretend like I will work in the ICU in the future.
Yeah.
I did my 1 month in residency. I will not be working in the ICU ever again. But in that setting, it's often hopefully one-to-one nurses, where there's one nurse per one patient, and a lot of times, these patients are under a lot of monitoring already.
Yeah.
If we could have the telemetry devices be able to communicate HRV to us, even if it's a leading measure, like you said, if a nurse communicated to me, hey, my patient's HRV went down by this much, I'm noticing it, maybe I'm in addition to that, I'm noticing some, changes in mental status, or maybe in addition to that, I'm noticing, their blood pressure is kind of going down, right? It's always all those measures together. Whenever I get like a piece of information, if I'm, in a different area of the hospital and somebody communicates to me, somebody's blood pressure went down, I'm not just going to say, let's give them fluids or let's put them on pressors or we're going to, give them this really hardcore medication to fix it. I'm always going to go, well, what else is happening, right? Like, did they just sit up from laying
Yeah.
down for a while? Like, give me more information. I can't, I want more of the vitals. I want more information. I can't make a clinical decision based on only one value. And I think it should always come back to that. And in an inpatient unit, there's less monitoring outside of the ICU. So I don't know exactly what the nursing ratios are. It varies dramatically depending on where you're at. Usually it's not as good as it could be.
Yeah.
But with that aside, there's less monitoring. Some patients are on telemetry continuously, so they're getting that continuous monitoring.
Mhm.
But other patients are not on telemetry at all. So then we just kind of have to figure out, how, depending on what that patient's diagnosis is, what kind of monitoring is necessary for them, and then what information in addition to HRV gives us the full picture. So for example, like a patient with a neurological injury, like a stroke or spinal cord injury, something like that, maybe the other information, the other metrics I need to leverage are different than somebody who had a heart attack.
Yeah.
Maybe those measures are going to be different. We really have to tease out, how we use HRV, not just standalone, but all the other metrics that are best used in combination.
Yeah. Dr. Lackey, let's put that sort of thinking on psychology, psychiatry, because I mean, a little bit different situation. I mean, you can be an inpatient psychiatric treatment, but outside that realm, somebody in an outpatient situation, what do what do you think we should be doing? What could we be doing? Do we hit the same thing as SDNN is going this way, RMSSD is going this way, but not quite as much, and then high frequency is doing its thing as well? Do we hit some of the same issues? Could HRV, I kind of see it, it gives us a warning sign potentially, but I'd love to get, as people are trying to use it for diagnosing, I don't think we're there yet. And I don't think many authors and researchers would say we're there. Just kind of what you kind of see with all these different metrics out there and maybe any best practices in that arena.
Best practices, I would argue, are still just like we actually recommend in strength and conditioning. Like, what's your baseline and what's that fluctuation? There is still just like too much about perception. How are you integrating? Like, there's some of the newer literature on looking at HRV and racial discrimination and experiences over time. And those are some very large numbers. We're having some good correlations and other things like that, but we just need to nest that in context too, of like, how was their day like earlier? But there's not really good ways to measure and or do that, right? So that's why I talked about that clinical context earlier, again, with using biofeedback. I know I have that hour. I can check in with them in that first 5 to 10 minutes of how they're doing. Does that perception line up with how their HRV was maybe the last appointment or other things like that? Then as you continue to talk about other things, or maybe even as you're practicing the resonance frequency, how are kind of things changing and going?
Yeah.
Yes, always disclaimer, you cannot interpret HRV when they're doing resonance frequency breathing. And yet still it's that checking in, and what is their perception matching up with what their body is telling them, right?
Mhm.
Our brain does so many amazing things, but then that inherently makes it that much more difficult to study and quantify and specifically say it's this thing and not that thing. Is the ANS at that point responding to the physiological thing rather than the psychological thing that's affecting the physio? And however that relationship goes around, right? Um, it is a hard question. So it from a clinical psych perspective, definitely always nest it in patient perception and what they're telling you just as much as what the data is telling you, right? There are two sides of a individual's experience, story, and what's going on. Um, and it's just we need to fill in more holes. I want more of our holes and our logic kind of filled in. We're never going to be perfect. We could go philosophical right there. We're never going to be perfect. We cannot understand everything in the universe as much as we want to. And so it really is. That's why, again, I said earlier that like pragmatic side of the aisle. My research brain can go a million miles a minute, but that's not helpful for the patient, the individual in front of you, that you need to nest that data within to help them.
I
Yeah.
think that's what was really cool about us doing a narrative review rather than a different kind of paper. It really just allowed us to have that time to really investigate each of these different areas of healthcare, and really kind of evaluate like where are we and how much work do we need to do in each of these settings.
Yeah. And then it's always the hard thing. I think the point, and this is where, as somebody who's lucky enough to be fairly healthy, I usually get my vital signs taken and my blood drawn once a year. And I'm fortunate to have that. What the heck does that say? It probably says more about what I ate in the last 24 hours. I remember I went, unfortunately, to a Nepalese buffet before one of my annual blood draws, and it wasn't pretty. Like, it kind of wrecked some stuff. But so I got retaken a few days later, and I was back to normal. So it's just this interesting thing. And all these not all HRV studies, but so many of them, you go into a lab, you take a baseline. Yeah. What's that? I mean, it tells you a snapshot of that, and you may have had the worst day of your worst night's sleep of the last 3 months the night before, and then how's that influence the results of whatever we're trying to measure too, which is a frustrating thing about this, and why I think baselines over time are probably our best bet, whether it's performance, I love the part on chronic disease management, because I think it's so key to that, is we need those, whether you got the Oura Ring or Whoop that takes it at night, or you put something on in the morning to take it, that regular measurement is, I think, where the gold lies now. Because I have more confidence than pretty much anything else at this point.
Yeah.
Absolutely. I mean, we just don't have a lot of other options, and continuous monitoring of many different metrics are really becoming more popular now. I
Yeah.
mean, we have continuous glucose monitors that people are wearing, even though they don't have diabetes, right? So this continuous monitoring is really becoming much more popular nowadays. And I think there's a good point to it, right? Even with glucose, if you get it measured once a year, for most people, that's probably fine until something is wrong, right? And it's so dependent, even your A1C is dependent only on the last 3 months, right? So even that one is like, okay, that's a one measure of 3 months. What about before that? What about after? And really being able to look at like continuous measurements are really the key. It's cool that a lot of these devices also share other metrics. So
Yeah.
talking about like resting heart rate, heart rate recovery after like a high intensity effort, like there's other really cool metrics that we can be detecting with these monitors, which is great. But HRV, like you said, is unfortunately behind the proprietary algorithm of whatever device you're using. And so, we don't have full access to how these things are calculated. But, really, like you said, I mean, we know of we call it white coat hypertension, when a patient comes in and they have hypertension only when they're in the office, right? Like that is a thing. It is real. And so we have to have an understanding of, okay, we'll give you 5 minutes,
Yeah.
chill out a little bit, and then we'll check it again. If it's still high, we'll say, go check it at home, and if it's normal at home, we're not going to treat it, right? So, at least for most people. So, it's interesting. I think if we understand that that's how it is with, blood pressure, for example, like we could imagine that heart rate variability could give us a better measure of, that over the last year,
Yeah.
how has your health been, right? Like let's look at trends a little bit better rather than like that once a year marker, and I think it would just give us some really great insight.
And to
Yeah.
just validate that more, thinking about the chronic pain side of the aisle, is just because there may be damage in one sense or another doesn't mean they have chronic pain.
Right.
I'm going to butcher the numbers. I don't fully remember the exact numbers of the study, but there was a big study that came out a little while ago looking at scans of the spine and thinking about how many normal people at like 50, 60, 70 actually had a damage of the spine. And like 60, 70% did. And way less than that actually complained of pain.
Yeah.
So with that ideology, it really comes down to, and I'm going to sum up both with what you both said is, if I'm remembering correctly from my methodology class, it's the demand characteristics of what is the situation presenting in our perception, just like Jen said with the white coats, just like you, Matt. Were saying earlier with what else was going on in their day. Did they have a stomach bug or something else, right? Like those demand characteristics matter and need to be nested in the interpretation of what's going on. And that's part of why the resting HRV is so helpful, or the nighttime HRV is so helpful, because what else are we doing? Our body is at least sleeping, regardless of stage of sleep. That may or may not affect HRV. And like we can control for so many other things without needing to be a self-report of our own brain supposedly interpreting something accurately about our bodies.
Yeah, absolutely. And I find it fascinating too. We kind of talk about this 25. I think a lot of people who wear, the 24/7 wearables think that their HRV is being monitored 24/7. And you can do that, and I think it sounds like, if I'm reading the research right, certain heart conditions, things like POTS, for example, there may be like ultra low frequency, might be something that is going to be useful. But I think for most people, you're just going to get a lot of artifact throughout the day and it's going to be meaningless. So it's, all this stuff. And I see a lot of research out there for people who haven't thought this deeply about some of this stuff. And it's like, oh, we measured HRV during a tennis match. Well, okay.
Or wrist, yeah, you're monitoring on their wrists while
Yeah,
they're like this. Like, do we
Let
think that's
alone
accurate?
just what parasympathetic activity is going to be there when your body's actively responding to stimulus that are activating the body. Why are you trying? That does not make sense. There's a relaxation response. Maybe
yeah,
at certain moments, but not consistently.
yeah,
That's what
exactly.
was really
So it's,
cool for us to really explore with the strength and conditioning paper too, is we kind of talked about, different metrics that are better for different situations. Like heart rate recovery is such a good dynamic
Mhm.
measurement of recovery from a highly sympathetic activity,
Yes,
from a highly exhaustive activity. And it's not really used all that often, but I mean, it's a great metric. And so, getting the HRV side from a more parasympathetic perspective, and then getting the heart rate recovery from that recovery from sympathetic, like
yeah.
you have more of a complete picture.
Yeah, I love that. So I always like to wrap up, and I'm going to give a little bit more of a runway for us because I really think we've already kind of set this. Usually my final question, but I'm sure it'll lead to some more. Is so let's say 5 years from now, I go to the Addleman lab at Stanford. NIH just gives you $1 billion to fix this. We've got AI, which I think a lot of our frustrations. I wonder if SDNN tells us something than RMSSD. I've never got a great answer to that question. And is it even worth asking? Because of I don't know. But let's just say, you got $1 billion, you got your lab at Stanford. I'm curious what you would like to do. Let's just say you have 100 staff working for you, so you can really be ambitious with this to address some of these issues that you see. Where would you think using these resources, the money, the staff, the opportunity, where would you start to fill in some of the gaps you found through the narrative?
Absolutely. I think, we really need more prospective studies. We have a lot of retrospective studies, and a lot of them are not randomized completely. So we need to start there, right? Like, let's just get some good prospective randomized studies, really isolating HRV as a measure initially for each of the diagnoses that we talked about. Some being chronic, some being acute, some being acute on chronic. Lots of variety in the diagnoses that we talk about across different specialties.
Yeah.
And if we can really figure out what measure of HRV is best applied for that scenario, for that diagnosis, is it best measured in an inpatient setting, in an outpatient setting, in both? And then figuring out how do we apply HRV with other clinical measures in these clinical settings when there are other things going on, and understanding how, really giving providers the confidence that they can use heart rate variability to give them some meaningful clinical information that they can then make a clinical decision based off of.
Yeah.
Not just like, oh, the patient's HRV went down. What am I going to do with that information? And helping really provide that confidence for providers to then utilize HRV in all of these different settings for all of these different diagnoses. So I would just be pumping out paper after paper with big sample sizes and really just getting some good information kind of across the board.
Love it. Okay, so now let's visit the Lackey Center. Like, what are we going to be? You get the other part of that big $1 billion grant. You'd probably be surrounded by 18 screens at that point, I'm sure. but what would you like to be? What would you use that money for to start, plugging some of these holes and pushing the research forward?
I mean, I honestly think rather similarly. I know we talked during the last time I was here is in chronic pain, even like HRV is a general measure. So no matter if somebody's got fibromyalgia, CRPS, they're coming in with a lot of severe arthritis pain, whatever it may be. Well, the body's responding to that threat. So HRV is going to be decreased no matter what you do, right? It's a little bit less specific there. I think if we could, I might actually go a little bit larger than where Jen went right there is I do
It's hard to
think
do.
I do think that the retrospective right now, if we had a big enough data set from a large hospital system that was effectively coded, right? Trauma surgery centers need to code all of their cases to make sure that they're meeting standards, that they've done everything. So that's would be some very good reliable data if they were also looking at HRV. I think that could actually be a very helpful if they were all measuring HRV. Big caveat, but that could be a very big thing there of just are there any big data ideologies of HRV could be helpful to then spawn further supplemental research. Now that's a very big health psych side of the aisle. Otherwise, as always, very pragmatic. What other diagnoses and conditions could biofeedback be helpful with? There is the rather large study that I overtly wanted to put in this paper, and I did, of biofeedback helping with dropout rates with trauma treatment. That is such a huge deal with such a high dropout rates from trauma treatment, that the fact that biofeedback just reduced the amount of dropout and was just similar symptom reduction, or I think maybe a little more. I'd have to reread that article. But the fact that it's having that big of an effect, just doing our small adjunct biofeedback to help with their autonomic regulation, fantastic and great. I am hopeful. I would want to add spaces like that where can this thing, because the body's going to respond to stimuli, we're going to be stressed out, is giving more tools that calm down the physiology to also help calm down the psychology of everything going on. Where else is that helpful in the medical setting to then also help people's patient outcomes? Just that's it. How do we help people? Because that's hopefully what this is all about at the end of the day, right?
Yep. And I'm curious, Dr. Lackey, I want to also come to you, Dr. Addleman, as well. HRV it's another whole interesting thing with swimming in the research, because we've sort of been talking about HRV metrics, 5-minute, 3-minute, RMSSD, breathing normal. And then there's like something that's so related yet so separate. And I love how you speak about this, because you bring them a little bit together. But I think a lot of people who use HRV as a metric in their studies, especially if they are measuring a couple different things, I don't even know if they know HRV biofeedback exists out there. And kind of technically, if you look at your overnight HRV score, you're getting some biofeedback there. But I know we're talking about meaning. So I wonder, Dr. Lackey, is there any room for integration there, or do you just think these two fields will develop kind of independently moving forward?
I would bet independently at first. I do think in the conditions where Yeah, there is a clear difference between disease progression and changes in HRV. We could then jump in with biofeedback and say,
Yeah.
does that help with regulating the body? But as we've kind of said all along too, it needs to be a condition that's could be helped by that. Or maybe it just has a lot of comorbid anxiety and depression, and we can help treat that with the HRV so they can then focus on the other medical care, right? I am not about to say and sit up on a high hill with commandment saying that biofeedback or HRV are going to cure diseases. Absolutely not. And as much as that would be cool, that's just not reasonable or pragmatic. HRV is detecting, helping to not only yourself, but our modern science understand, hey, something is up, whatever that is, perception, something wrong with the body, just changes the temperature even, right? Like it is the integration system that we are just able to interact with without it being actual neural signals in the brain.
Yeah.
And so I want them to be closer together, but just like I was explaining earlier with the like methodological jumps that we kind of need the HRV first, unless we have that theoretical reason why this disease is very autonomically regulated. We now believe that given whatever other things. Let's already jump in with the biofeedback as an adjunct, and we can also, through doing that, get the HRV metrics at the same time. But I really do think for most conditions or other fields in general, it's going to need to be the HRV first so we can say, ah, there's a perception difference. There's something in the body that's being picked up to give us that HRV difference to then connect the maybe biofeedback or something about it could be helpful. Because
Yeah.
although I'm talking about HRV biofeedback, you bring up the good point. All of it in some respects is kind of the biofeedback. That's why we also do temperature. We do EMG. Um, Neurofeedback is its own separate rabbit hole
Yeah.
I will not touch, but still it's all elements of getting feedback from the biology that's going on that we may not always be aware of or as sensitive to, and feeding it back so our brains can integrate it whether conscious or not.
I love it, Dr. Addleman. We'll kind of wrap up. You haven't talked much about the biofeedback, but I know in the performance space, it is there as well. I'm just curious, sort of your experience with that side of it. I just love to, out of curiosity, kind of know how that sort of maybe informs any of your work or thinking as well.
Yeah, I would say this is definitely more Nick's wheelhouse than it is mine. More of my time learning about HRV was spent as a metric.
Mhm.
And really, most of the things that I've learned were kind of along the way with crafting this paper, as well as learning from Nick himself, because this is definitely an area that he's incredibly knowledgeable about. And I'm just kind of only on the edge of it. So I can't really speak much to how it's applied more in like a sports performance realm because I haven't been exposed to it as much.
Yeah, I just think it's an interesting space that does not overlap. I even see biofeedback research that doesn't necessarily measure HRV as a metric sometimes, too. And in the psychology space, I think the two most powerful, probably over the last 3 months research I've seen, is there's indication that HRV biofeedback could, and I'm using could, may, we need the next step of research, be a standalone treatment for things like trauma and substance use. Now, I'm not there to say it is, but there's some really well done research too that just shows as a powerful indicator. I'm still in the place, it's the ideal homework. But I also think it's probably the ideal homework for everybody. Whether your performance brings you into this or mental health issues or chronic disease, it seems like a regulated autonomic nervous system is pretty important. So it's
For anybody listening to this podcast that is aiming to become a licensed psychologist and or has taken the EPPP in the past, it sounds as if you're kind of basically just calling out how we conceptualize humans and people and perception and our level of awareness. So no matter what kind of theoretical theory, what from psychology, psychiatry, or whatever of how we conceptualize the mind, it goes back to this idea, how aware are you and how engaged are you in your life from whatever perspective, conscious, unconscious, all the way back from Freudian to modern CBT of just what's going on and being able to think and integrate and not have automatic reactions to our experiences, right?
Yes.
It's another tool to get in there no matter what theory you're coming at it from. And I think that's what's kind of shining through. And everyone's guilty of it, but these things incentivize really being disconnected. And so, wow, this is an interesting research question you have just brought up in my brain. I wonder if there would be an interesting difference between if we took somebody from 50 or 60 years ago, like a 30-year-old from 50 or 60 years ago, to a 30-year-old now. Would there be a difference in their base kind of level of awareness? It'd be very subjective, but still, just given of are people more or less connected in that way, and then relate that to are they perceiving some of those differences in that anxiety and that HRV in their body?
Well, it sounds like a great next episode once we publish that paper. So I love it. Dr. Addleman, it's such a pleasure to have you on the show. Dr. Lackey, yeah, it's just great to have you back. So
I'm sure I'll be back when I can get more engaged with the lab at some point in the future.
there we go. We just need all of that billion in funding to solve all these problems. So I appreciate you. We'll link to the article. I'll get the links to the previous article as well if that's available for folks too. It's a must read. Like I said, I like Nick somewhat just for me and him. I was like, and he does really good work. And I was like, oh, he's got a good partner with this one because it was just such an important piece of research that it's just desperately, it almost needed probably every 3 months with the amount of research that's coming out. So I want to thank you both for, the brilliance to pick this approach and to give this gift to all of us out there. So thank you both very much.
Thank you so much, Matt. It was great to be here. Very nice to meet you. Hopefully I'll be back eventually too, but it'll take a little bit of time in my training to be out there publishing more papers. So
well, we'll all get to the Addleman Center at Stanford soon enough.
Right.
So.
Yeah.
Or wherever it's located. I know Stanford just might be a stop along the way. So
right.
But thank you. I appreciate you both. And as always, you can find show notes, resources, more information about our guests at optimalhrv.com. Thanks, everybody, so much. And as always, we will see you soon.